Wonderful. Good morning, good afternoon, and good evening, depending on which part of the world you are in. Let me welcome everyone to this almost monthly series of webinars that we have been holding as a part of the Harvard Chan India Research Center. My name is Vish Viswanath. I am the Lakeham Key Professor of Health Communications at Harvard Chan School of Public Health and Professor of Population Sciences at the Dana-Farber Cancer Institute, the Dana-Farber Harvard Cancer Center. And the Harvard Chan India Research Center has been operating. It's the first physical footprint and the global center for the Harvard Chan School of Public Health. Located in Mumbai, the center's foci are threefold. We facilitate and help faculty do research on public health in India in collaborations with colleagues from India. And second, capacity building and developing public health workforce. So we hold a number of workshops, training seminars, and facilitate scholarly exchange between students and faculty, and exchange of students and faculty between India and the US or at Harvard. Third, which is germane to the conversation here today, is that the third foci is the translation and communications. We do our best to translate evidence base that is extant in the literature for public education to make sure that the conversations and discourse around public health problems are evidence informed. As you can see, especially with the COVID-19, sometimes a lot of these conversations and discourses are evidence free. We try to our best to translate that evidence base to influence both public health policy and practice. So this conversation today is a part of that effort. And we are delighted to have three very distinguished panelists. As many of you know, as someone characterized it to me, India is going to be the diabetes capital of the world. I don't know what that means, really, but certainly, these phrases are bandied about by people, but the facts are pretty compelling. Because of epidemiological transition, India's burden, both mortality and morbidity associated with non-communicable diseases have been rising. At one time, people thought we should focus only on communicable diseases or at least give more weight to them. But it's very clear with this transition and growing economic power of India, there are non-communicable diseases which are contributing to the mortality and morbidity in India, particularly diabetes, because of changes in lifestyle, consumption, food habits, transportation, and other variety of environmental factors, as well as individual level factors. Diabetes is a growing problem. And there are many numbers out there that can be shared. More than 80 people, according to the latest data, are affected by diabetes. If these numbers may be even underestimates, but the projections are that the numbers will increase considerably. Almost 1 in 10 is likely to have diabetes, by 2030. And these are projections, but obviously the story behind those projections is important. The story is this is a serious problem that requires change, understanding, as well as modifications of behaviors at the individual level, as well as policy steps that can facilitate behavior change. So we could not have found three more important people to help us walk us through this serious problem. I'm delighted to have three people. I will briefly introduce them. The way this panel will work is that I will ask each of them some opening questions, and then I will follow up those questions. And at some point, we will open it up for audience questions and answers. So please, if you have questions in the audience, please put them in the question and answer box, the Q&A box. One of our staff members is monitoring it constantly, and she will share the questions with me so that I can ask the panelists. So let me go ahead and introduce our distinguished panel here. To my right, or to your left, I guess, I'm going by the screen here, is Ms. Roli Singh. Ms. Roli Singh is an IAS officer who is the Additional Secretary and Mission Director of the National Health Mission in the Ministry of Health and Family Welfare, Government of India. She is a graduate of London School of Economics. She belongs to the 1994 IAS cadre from Rajasthan. In her vast career, spanning almost 28 years in civil service, she has worked across a variety of sectors: health, medical education, women and child welfare. She has held important positions in the Department of Personnel and Training, HR, and capacity building wing of the government. She has also held positions at the premier training academy for public administration in India, the Lal Bahadur Shastri National Academy of Administration. So we are delighted that Dr. Roli Singh can join us. Thank you, Ms. Singh, for joining us. Next, I see Dr. Frank Koo. Frank is a close colleague, friend here at Harvard Chan with me. He's the Fredrick Stair Professor of Nutrition and Epidemiology at the Harvard T.H. Chan School of Public Health. Dr. Hu also chairs the Department of Nutrition here at Harvard. He's arguably one of the most prolific scholars in the field of NCDs and nutrition and epidemiology. He's a graduate of the medical school in China, the Tongji Medical College, and has an MPH and a PhD from University of Illinois at Chicago. He has published a textbook on obesity epidemiology, which is a classic, and has published more than 1,400 papers, peer-reviewed papers, which are all very highly cited. He has won a number of awards. He served on a number of prestigious committees for the National Academy of Medicine and Sciences here in the US. And he was elected to the National Academy of Medicine in 2015. So Frank, thank you for joining us. Third, we have Dr. Monika Arora, who is the Vice President for Research and Health Promotion at the Public Health Foundation of India. Dr. Arora is also the chairperson. She's a president-elect of the NCD Alliance, as well as a chairperson of Southeast Asia NCD Alliance. She's a founding governing board member of the Healthy India Alliance. She has been published extensively. In fact, she has done a lot of interventions to change behaviors among youth and adults. She has established herself as a credible scholar in NCD prevention and control, and she serves on a number of national and international committees on non-communicable disease prevention and control and childhood obesity. She has been honored with a number of prizes and awards, and including the World Health Organization's Director General's Award on No Tobacco Day, Exceptional Women of Excellence Award, and many other awards to mention here. She has also an extensive track record of peer-reviewed publications. Dr. Arora, thank you for joining us. All right. So without spending a lot of time, let me just open up and just for the sake of conversation. So if you want to unmute yourself for the sake of conversation, just let me say, ask each of you to from your perspective. So you are sitting in different positions, not in terms of your disciplinary backgrounds and practice backgrounds and policy backgrounds. So from your perspective, what are the 2 or 3 most urgent issues? Number one, let me ask you from your perspective, why should we pay attention to diabetes compared to a number of other problems that are prevalent in the world today? And what are the 1 or 2 compelling things we need to do to address them? So maybe we'll go with you, Dr. Hu, Frank, because I understand given your, you can take the global perspective on this, and then we can go to the other panelists.
Okay, thank you, Dr. Vish. It's really a pleasure to participate in this webinar. I have a couple of slides to show. Let me see. Can you see it?
Yes.
All right. So as Dr. Vish just mentioned, we are in the midst of global obesity and diabetes epidemics. A major research question for us is what are the drivers of this global pandemics of obesity and type 2 diabetes? There has been long-standing debate whether this epidemic is due to genetics or due to environment or due to nature versus nurture. There has been extensive research on genetics of obesity and diabetes. I think now it's pretty well recognized that even though genetics is important, it plays a relatively minor role in the current global obesity and diabetes epidemics. The major drivers of the current obesity and diabetes epidemic is actually due to changes in environment, primarily due to 3 transitions, namely nutrition transition, epidemiologic transition, and the demographic transition. So nutrition transition means transition from traditional diet and lifestyle to westernized diet and lifestyle. Epidemiologic transition means a transition from malnutrition and infectious diseases to chronic non-communicable diseases. But in many populations, there is a coexistence of undernutrition and overnutrition. And demographic transition means a transition from high fertility and high mortality to no mortality and no fertility. That needs to accelerate the aging of the populations. So why are Asians at a high risk of developing type 2 diabetes? This is another research question that we have studied extensively. We know Asians have much lower BMI levels compared to whites, but Asians have much higher prevalence of abdominal obesity or visceral adiposity compared to whites, given the same BMI. Asian populations also have high prevalence of cigarette smoking, exposure to air pollution, high level of stress, and also high levels of sedentary lifestyles. In addition, high consumption of refined grains, such as white rice, have also become an important risk factor for diabetes. And there is also increased consumption of Western style fast food and ultra processed foods in Asian populations. And another important risk factor is exposure to undernutrition in early life. As I mentioned earlier, in many low and middle income countries, there is coexistence of undernutrition and overnutrition, especially undernutrition in utero and in early life, and then overnutrition in late life. This kind of combination put individuals at a high risk of developing insulin resistance, metabolic syndrome, and type 2 diabetes in adulthood. We know that traditional Asian diets, including Indian diets, have many beneficial aspects, including the high consumption of green leafy vegetables, cruciferous vegetables, high consumption of legumes, beans, and soy, and a high consumption of nuts, including peanuts and seeds, high consumption of unsaturated cooking oils, and the high consumption of phytochemical-rich herbs and spices, and low-calorie beverages such as green and red tea, and also fermented vegetables with healthful probiotics. However, there are many changes in the traditional Asian diets that are cause for concern. This include westernization of the diet and lifestyle, and the increased consumption of fast food, especially among young people, increased consumption of soft drinks and other sugary beverages, increased consumption of red and processed meats, and high consumption of refined grains, especially ultra-processed grain foods instead of whole grains, and also increased exposure to obesogenic food environment. So this kind of dietary pattern has been associated with increased risk of developing insulin resistance, metabolic syndrome, and type 2 diabetes, especially in Asian populations. So those are the factors we're going to discuss today in terms of their role in the etiology and also prevention and management of type 2 diabetes that are very relevant for Asian populations, especially India. So I'm going to stop here. I'm looking forward to the discussions.
Wonderful. Thank you, Dr. Hu. That was very helpful. That was a great diabetes 101 information. I think that's there are a few technical issues I want to come back and talk to you about. But before I do that, so Dr. Arora, I think I want to go to you next before we go to the policy perspective. So you have done a lot of work on NCDs in India, including diet, tobacco, and a number of these lifestyle factors Dr. Hu mentioned. I'm glad he also talked about the obesogenic environment, which is important. But you have focused on the larger environmental issues and tried to do behavioral changes within those. So tell us from your perspective, just give us some, why diabetes is such a compelling issue, and from an Indian perspective, especially.
Thank you. And my job becomes very easy with Dr. Hu explaining the various determinants that influence the rate of diabetes that we are seeing today in India. So I'll just add that Dr. Hu did mention about smoking, but apart from smoking, smokeless tobacco is our greatest burden in India and even in Southeast Asia region. So there is now evidence of association with smokeless tobacco and type 2 diabetes as well. So the whole lifestyle definitely has a role to play, but also the environment is not conducive. It is very easy for us to talk about nutrition, but this is what we would hear from maybe Ma'am Singh about. We talk about healthy food options, but what we get to hear when we do interventions is healthy food options are not affordable. We do give recommendations of 5 fruits and vegetables in a day, which are absolutely not affordable, even in urban setting, if we talk about with the prices. Then the whole policy environment around physical activity, people living in slums are unable to practice any form of physical activity because there are no roads available. There are no cycling tracks available for people to be physically active. Environment, which is the climate, is another reason in cities like Delhi, which prohibits people from being out even early in the morning with the air particulate matter, which we all have been hearing about. So it's congregation of challenges. When we do interventions, we have to be very cautious about what we are proposing as our message. It's not very simple. The same messages we wear here in West cannot translate to Indian context. So we have to contextualize a lot of messages on lifestyle. Having said that, definitely we know that there are rural-urban differences. We are seeing more obesity in urban areas as compared to rural areas, and as a result, diabetes is higher. But even in urban areas, we have started seeing the urban slums are the worst hit, because people there are unable to eat healthy, they are unable to be physically active. Those who are high SES in our research studies have shown that they are able to be physically active. They can even afford to go to gyms or have personal trainers. So that is the inequality that we are talking about. But most importantly, I would like to talk from the community's perspective. We do research, but I work a lot with the people with lived experience. And citing one example, when we talk to a patient, and this is in an urban Delhi setting, when I spoke to a patient, what do you do for your diabetes? Because management is a big issue when we talk about diabetes control. This person, well educated, said, I take a white tablet in the morning. He did not even know that he takes metformin or what medicine in the morning. So I think we as public health professionals, doctors, we have completely failed if we have not empowered patients, because they have to take charge of their own health. Definitely policy environment and all is something that we have to work on. But if we look at individuals, I think the most important part is that we engage communities and patients more meaningfully. We have a multi-sectoral action plan for prevention of NCDs, where we have various stakeholders. We have civil society as a stakeholder. We have 34 ministries who have a role, because they will be the ones who will address the pricing issue, the walking issue, cycling issues. But patients have to be an important stakeholder on that multi-sectoral action plan, because we are talking about a whole of community approach when it comes to NCD prevention and control. So I would just like to emphasize on that aspect, that this is the need of the hour to engage our patients more meaningfully. I'll stop here.
Thank you so much. Really appreciate those remarks from an Indian perspective. So, Madam Secretary, you have a very enviable or unenviable position of really translating these, translating the research into policy steps and executing it and implementing it. Particularly it's challenging given that your RIT is all of India, more than 1 billion people, and with multiple competition from multiple issues. So tell us, how are you managing this? From your perspective, why should we focus attention on diabetes and NCDs, and what are the challenges you are facing?
Well, at the outset, I would like to thank the Department of Harvard Chan School of Public Health India Research Center and all the organizers who are here for organizing this event. It is a very important area, and I think it's very important that we deliberate on these issues, at whatever fora that we get. And I was very fortunate to hear Dr. Frank, who gave a very lucid explanation of why these kind of, why diabetes is such a public health issue as it is today. And we in the government recognize that. I would just like to make a small correction. I'm additional secretary. I'm not yet Secretary Health. So I report to the Secretary Health Government of India, but I look after the National Health Mission as Mission Director. So yes, it is a huge onerous responsibility that I have, and I can very humbly say that it places a lot of a lot of onus on us to do something about issues, the non-communicable diseases that are confronting the population today. So as Dr. Frank pointed out, and Dr. Monika also has reiterated, there is a nutrition transition that has taken place, and it is definitely one of the reasons. I can give an example from my own personal, because I believe in anecdotal and personal experiences matter a lot. I come from a family where none of my parents, either from my mother's side or the father's side, were diabetic. I'm not diabetic. My husband is not diabetic. My son, who's an adolescent, has grade 2 fatty liver. And it is a serious concern for us. He is just 13 years old, and we know that there is a lot of sedentary, last 2 years of being completely sedentary, not having much, outlet to, play. But at the same time, we also recognize the fact that there has been a shift in the diet. There has been a shift in the food that we used to eat. So definitely there are changes in the gut biota that have taken place, and that have affected his, his way to metabolize the food that he's eating, because genetically probably he's not used to processing that kind of food, but he likes it. And we, as working parents, are very constrained to, really not being able to stop them at a certain level. We also concede and we say, okay, fine, these are new things, we all need to try world cuisine, and but at the end of the day, it is not, everything is not healthy, and especially when it is cooked outside, we really don't know what kind of trans fats are going into it, what kind of processing is going into it, and definitely the packaged foods are very high on salt and sugar. We're all aware of that. So this change in lifestyle, the nutritional patterns, these have had a very huge role to play. And as Dr. Monika pointed out, the problems with people who do not have, that kind of financial heft, but there is a problem of undernutrition and malnutrition as well, that leads to a certain kind of, nutritional imbalance in the system. So we in government have recognized it as a serious problem, and we have a program for control of non-communicable diseases, which looks at the 5 major, common diseases, as we call them, basically hypertension and diabetes, and 3 types of cancer. We're looking at oral cancer, which tobacco incidentally is one of the biggest contributors of oral cancer in our country. And yes, smokeless tobacco, more than smoking tobacco, is a contributor, and we recognize that. And there is also a lot of emphasis on treatment of cervical cancer, cancer of the cervix, which young adolescent girls are getting affected by, mostly women. So the whole program, the whole idea is to do population-based screening. And we have started the Ayushman Bharat Health and Wellness Centers and the Ayushman Bharat Jan Arora Yojana, in which we have the idea is to screen as many people as possible above the age of 30 and put them on the treatment for diabetes as we come across them. And we have screened more than 23 crore people as of now for diabetes, for diabetes, and about 31 lakh people, I don't know, and you need to translate it into millions, 31 lakh people are on treatment of diabetes as on date. So the problem, as I see it, because you asked us to tell me the 2 big issues that we think that we face. So in sitting in government, I can tell you that one is scale. India is a huge country. We have a huge population to deal with. And our mission to universalize healthcare, while it is on track, it still has some distance to go before it gets completely established, because our the upgradation of infrastructure and placing of manpower, trainings, all that is still work in progress. We have a target of setting up 150,000 health and wellness centers. We have already achieved 1.22 lakh health and wellness centers which have been operationalized. But a lot of things are still work in progress. So trainings, I believe, are very critical. Training of our manpower, which is placed there, as to how they should be screening, what should be a clinical examination, be looking like, and how how they should be putting, what standard treatment guidelines need to be followed. While there is availability of drugs free of cost, there is a whole what do you call, a list of essential drug list which is maintained, and those drugs are provided free of cost. But how much to medicate, when to start people on medication, those are very iterative, and those are again have to be ingrained in the behavior of the health service provider, and it has to be a continuous process of training and iteration. And at the same time, like Dr. Monika pointed out, the awareness in the people that needs to be there. That is another big responsibility on government. And I think all stakeholders who are here and many more who are working in the field of public health need to come together, because a lot of community awareness needs to be there on what is right kind of lifestyle, what is right food. And while I mean, I do have, I mean, I'm sensitive to the slum issue that you raised, Dr. Monika, but, you know, by and large, we are blessed to have, you know, our rural areas are open. We don't have to have, you know, really look out for places to walk in. And it's just that awareness that seems to be lacking. So our health and wellness centers are in the business of promotive healthcare. Well, the wellness aspect has to be promoted. We have yoga. We need to, you know, tell people about, you know, how to manage their lifestyle, the nutritional, you know, intake, what is it that's good for them, what's not good for them. So all that kind of messaging, that communication has to be really strong. It has to be something which is tailored for the needs. And we have diverse diets, you know, across the country. We have diverse climatic zones, so everything. So we are lucky that we have the state governments who are very much into this as much as the union government. And essentially, health is a state subject, and the state governments, many state governments have a very strong public health focus now. And there are states which have done, like Andhra Pradesh, for example, has done almost 70% screening of NCDs across the country, and they have across the state, and they have also mapped their population to the health and wellness centers. They have started creating ABHA IDs, which are your digital health cards, in a big way. So the entire country is now on a trajectory where we will be, you know, working in a more focused manner in this area. So I would stop there, and I would leave some room for questions from the, you know, the audience. Thank you.
Great, thank you so much. Really appreciate that perspective. I want to go back, just at least get a couple of clarificatory remarks and maybe amplify a few things you have said, each of you have said. So Frank, I want to come back to you, Dr. Hu. One of the things I often hear, or two things I really would love to have some clarification from you in terms of specificity, right? We often hear about the so-called Western lifestyle and Western diet. What does it really mean? You know, when we talk about Western life, Western diet, right? You know, specifics. And then I have another follow-up question to that, you know, so.
Right. Yeah, the so-called Westernized diet or lifestyle, I mean, it's very kind of generic term. It's not that specific. When we talk about Westernized diet, it typically means a couple of things. First, there is increasing consumption of ultra-processed foods. So as you know, in the US and other industrialized countries, most of our foods are highly processed or ultra processed. I mean, if you look at bakery products and bread and other carbohydrate foods, snacks, fast food, they're ultra processed. So during the industrial processing, many beneficial nutrients are removed, such as minerals, antioxidants, vitamins, and fiber. And those kind of foods have been shown to increase risk of metabolic syndrome, type 2 diabetes, and cardiovascular disease. And the second aspect of the Westernized diet is the reduced consumption of traditional plant-based components, such as fruits and vegetables, whole grains, legumes. And in this aspect, the reduction in healthy components of diets, especially plant-based components, has also been shown to be an important risk factor for diabetes and cardiovascular disease, independent of other risk factors like fast food or ultra-processed food. So again, this is a generic term, but typically mean the combination of those two things.
Right. Thank you so much. I wanted to be a bit more specific on it, as that phrase is often invoked. and this is a global problem, not just
Right,
a problem
right.
in India. So, Dr. Arora, you have done a lot of these interventions on so-called lifestyle. I'll come back to the more structural type interventions a little later. But what are the challenges? Why, everything Dr. Hu mentioned, legumes, dal is very traditional, very unique, very, very, very core to the Indian diet. The leafy vegetables he mentioned are very core to our diet. What is the challenge? What are the problems we have there in India?
So I'll cite two examples. So we have done interventions in the school setting. We all know behaviors get etched at young ages. So they start making their food choices from a very early age. So our recent study, which was looking at the advertising environment, which children are exposed to. And we looked at the programs which are targeted at children. We watched those and the advertisements which appeared during that period, and the ones which are watched by youth. Surprisingly, the frequency of unhealthy food items advertising was much higher in children programs. And these were all the sugar sweetened beverages, as well as the HFSS food, what we say, the foods high in fat, salt, and sugar. So they are being bombarded with these food items to the extent, and another anecdotal example I would give is when my son is scrolling something, he had ordered noodles online. And he's being bombarded with that every now and then, whatever he's scrolling. And he does say he's very physically active, very conscious about what he eats. He said, I get attracted every time I see that ad popping up. I don't want to eat, but this keeps reminding me. So, advertising is one very big reason for what choices they are making in the urban setup as well as in the rural setup. When we gave intervention for 2 years, and all the interventions have to be based on theories, health promotion theories must be followed into designing an intervention. So we gave behavioral intervention for 2 years, which was on knowledge, attitudes, and practices. And our pre and post assessment saw a very clear reduction in their carbonated drink consumption, in their foods and vegetable intake went up. Not that, this is something they do not know, but hearing it every now and then is similar to what they are hearing in advertising every now and then. We have to keep countering it with the right food messaging. And when we did this intervention in the school setting, the challenge was the school canteens, which were serving unhealthy food items. So we had to work on the canteen menu as well. What was being served in government schools outside school was all unhealthy fried food. So now government has a legislation with the food FSSAI, the Food Safety and Standards Authority of India, not allowing HFSS foods being available within immediate vicinity of the schools. So these kind of policy interventions definitely have an influence on this individual's choices and behaviors. So I would say that, yes, it is possible for them to come back to those traditional food and what was healthy, but it does require, constant reminding them of what is healthy and what it would lead to in future.
Great, thank you. The sun was shining right in my eyes, which is great. Anybody who knows end of November, December in Boston knows this is pretty cold, but we are fortunate to have the sun still out. I'm glad as a professor of communications, you mentioned advertising. And you mentioned changes that need to be, that you actually made the canteens change their dietary preparations. So what it suggests to me is that these interventions, we have evidence, pretty good evidence that these interventions do work in defined times and settings. But the question would be maintaining these over time. So and that's where policy comes in. So, Ms. Singh, I'm curious, given what you have heard from Dr. Arora and Dr. Hu, what are the challenges in taking some of these lessons we already learned and implementing them as a part of the policy? Especially you did mention the issue of scale in India. So what can we do from a policy perspective?
As far as policy on the right kind of food and what is good food goes, we have the Food Safety and Standards Authority of India, and it has been coming out. There is regulation. There is a lot of regulation on what is to be eaten. There is a regulation on the kind of labeling that needs to be there on packaged foods. There is a Safe Food and Balanced Diets for School Children Regulation 2020, which encourages schools to adopt safe foods, or the HFSS that Dr. Monika was talking about emanates from there. So it basically, the foods which are referred to as high in saturated fat or trans fat or added sodium or sugar. So again, I would say that the crucible of all the policy interventions are actually our state governments. So many state governments have taken a lot of these things up in right earnest. That, for example, in Uttarakhand, there is a campaign by the government to take back trans fats from these establishments which are which are selling food commercially, fried foods, our mithai shops and our halwais and all. So they take they pay them for buying that trans fat, and it gets converted into fuel. So there is a 90% conversion rate that has been established. The Indian Petroleum Institute that is located in Dehradun works on this, and the state government has used that institution to implement this very novel idea. So I mean, it's and there are state governments like Rajasthan which are doing Shuddh Ke Liye Yudh, where any kind of mixing or any kind of contamination in food is penalized very heavily. So there have to be penal positions. So all regulation have to work with with a carrot and stick kind of a thing, and penal provisions have to be strongly implemented. So the implementation aspect of regulation is something that we need to work at constantly. And again, it requires a lot of I would say training of regulators as well. Not only the public, the regulators also themselves need to be sensitized and oriented as to the importance of implementing that regulation and the kind of strictness that needs to be brought into it. So at the policy level, what needs to be eaten? Then there is we have our Tobacco Control Act as well, but the food safety regulations recognize the smokeless tobacco that is getting mixed up, the pan masala and the gutkas that are being sold. So there is a lot of regulation on sale of those gutkas in school, in the periphery of the school. So there is a binding that within 200 meters you should not be selling gutkas. And a lot of state governments have come out with their own gazette notifications, and they're implementing it very strongly. States like Tamil Nadu and Andhra, many states have taken it very seriously. Madhya Pradesh, and they implemented very strongly, at least around government schools and even private schools. So but the buy-in from the public, there has to be support from the public for initiatives like this.
Right.
And so for the information on what pill I'm taking. Similarly, the regulation is directed, it's meant for the public, end of the day, and the public needs to know that this is for their benefit. But there are always vested interests which would try to block these regulations for being implemented in the right spirit. And that is a tendency that we need to fight as a society and as a community and as citizenry. So an informed citizenry is what would lead to a kind of a social movement on these issues. So I think that's where media and communication, and you are the right person, Dr. Viswanathan, to tell us what are your prognosis on this whole thing, and how do you think government should take it forward? But I think communication is really very important. What kind of messaging to which sector? Say for example, if you're looking at adolescents do get those kind of nudges. Every time they open the screen, there'll be a nudge that, okay, fine, buy this noodle, or, there is this new game that is available. So there is so many ways AI is working these days that it's difficult to keep pace. You really, before we think of something, the AI is a little ahead, and the commercial organizations have gone 2 steps ahead. There is so much surrogate advertising which is happening, which we are not able to, pinpointedly stop, because they are talking about something which is not exactly the product that they're selling, but they're actually selling a particular product. So there is a huge challenge there. And at policy level, I would say that we need constant engagement with the people who are in the research field, and learn from the findings from the field, and do course correction wherever it is required in the policy.
Fantastic. Thank you. I would love to talk about communication. So this is where we spend a bulk of our time in my lab and globally. But I'm the host of the webinar. I'm a moderator, so I can't dominate the conversation. So hopefully I will say a few things another time. But before I want to take audience questions. So one of our colleagues in India, Khushbu, will be sending me questions. So so one question that come up, and Dr. Hu, I have been meaning to ask this, so it has really come up. It's in a very nice way here. The so-called gene-environment interaction and its impact on obesity. So we have here that there are studies both in the US, your colleagues, Dr. Bhupati Raju and others have done in India, South Asians in the US, and of course there are studies that are done. You invoked it, that genetics plays a big role, which could also lead to fatalism because it's all programmed, right? It's all genetics based. Can you address that issue and how we have a sense of agency and what we can do about it? So,
right, yeah. So this is certainly a very important question. As you said, there is a misconception that because diabetes runs in the families, so there is nothing you can do because it's all determined by your genes. Of course, I mean, the family history or genetics play a role in diabetes, but the role of genetics is actually pretty minor compared to diet and lifestyle factors. So far, we have identified hundreds of genes related to diabetes, but the effects of those genes are very small to moderate. Overall, they explain less than 20% of population differences in diabetes prevalence. And also, there is no evidence that genetics plays more important role in South Asians compared to other populations. Having said that, both genes and environment are important for the development of diabetes. And there is indeed an interaction or synergistic effect between our genes and our environment. So this phenomenon is regulated or controlled through epigenetic changes. So, of course, we cannot change the structure of genes, but our environment, our diet and lifestyle can actually change the epigenome. So epigenome is related to hyper or hypomethylation of the DNA or histone modifications. And those epigenetic changes can turn on or turn off certain genes and influence expression of the genes. For example, we have found that higher consumption of sugar-sweetened beverages can amplify the genetic effects of obesity, meaning that people who have high genetic susceptibility to obesity, if they also drink sugar-sweetened beverages on a regular basis, their risk of develop obesity or perhaps diabetes is increased multiple fold beyond the additive effects of simply just adding the effects of genes and the sugar-sweetened beverages. So this kind of effects, again, are most likely regulated through the epigenetic changes rather than changes in our genes. So I think this is a very important research topic because most of the studies have been conducted in Western populations, and very few studies have been conducted in India and other Asian populations.
Wonderful. Thank you for that, because I think that issue keeps coming up, leading to some kind of a fatalistic attitudes. So I wanted to address it head on before people run with it. So it's very clear from your remarks that the policy and environmental type interventions are very important in addressing that. And I want to go to both Ms. Singh and Dr. Arora on this issue. So one example, there are many types of policy interventions one can implement. One example that keeps coming up is the role of the public distribution system that has come up. It's a question that's been coming up here. So whatever food we provide to people, I think it's called the ration, public distribution system, whether it is sugar or rice. How can we integrate, say, be creative in this public distribution system to make sure that the foods our diets are much more healthy in this system? Maybe, Monika, you want to take a leap at it, and then we can go to Ms. Singh on it.
So quickly to address, this was a famous intervention from Finland, where the public distribution system oil was changed to olive oil, and how it brought down the cardiovascular risk in the population. But given the size and scale of India, I think that kind of intervention is going to be very, very difficult. And then we have to remember we are actually dealing with both ends of the spectrum. We are not done away with undernutrition here. So we have equal number of children and adults with undernutrition and overnutrition. So our messaging has to look at a syndemic approach so that we address both overweight, obesity, and undernutrition as well. So I think the way forward for us is strengthening our health system. And one example we have, again, from our group randomized trial done in rural areas in India, is where ASHAs, who are the frontline health workers, they were trained into carrying glucometers. They were trained in using glucometers, and they could do screening from door to door during their visits for other health programs. And that helped in diagnosing the pre-diabetics as well as diabetics, and that bridge to the health system by ensuring the diabetics are getting regular supply of their medicines through the health system. That is where we will be able to do a proper screening and also get the people who are pre-diabetic into the net, which usually gets missed. And also be able to do health promotion in the community. So in our intervention, we were able to bring down, within 6 months of intervention, HbA1c levels in the intervention group. So that came down by 6%, whereas it went up by 10% in the control group. So if we don't intervene, that is the level of increase we will continue to see in case of people not being managed. And similarly, the people with lived experience become a very important bridge between the community and the health system, because they have gone through the stages. So if we train them to become the health ambassadors, they will be able to do hand-holding within the community and spread this message of maintaining diabetes, proper nutrition. But I think in terms of just having the public distribution system, make it available, would not ensure they are consuming it. So we need to work on that end of the spectrum as well, with the people, with the community, and people with lived experience.
Great. Thank you. So, Ms. Singh, I want to come to you. I think these policy issues keep cropping up. So one is this public distribution system. A couple of examples from global examples are available. about its success. And advertising is another one, where there are a couple of very good examples where they began increasing taxes on advertising of sugar-sweetened beverages. That keeps coming up. And it looks like that kind of a taxes on advertising of sugar-sweetened beverages can potentially reduce consumption. And this is by a Harvard colleague of mine. He's working with a number of states in the US. So these, it's very nice and to do these kind of studies, research setting, these interventions. But as you rightly pointed out, you need public support for a number of these steps you're taking. So from a policy perspective, just give us a couple of, we just only have about 4 minutes, so we'll wrap it up, but just give us, maybe you can take the, some kind of a closing remarks on challenges in enacting this kind of a research into policy and what can be done to amplify that.
So I think you started with the PDS system, though it's not the subject of the health ministry, but I would still like to just inform you on that, when again, there has been a call from the highest level to, to encourage millets. This is the year of the millets, and Honorable Prime Minister has spoken from various forums on the importance of reintroducing millets in our diet, something that we have forgotten over the years. And because they were called, poor grains, and there was a lot of premium on a wheat-based diet, which happened in because of the whole food crisis that we underwent, and then there was this this whole monoculture for growing wheat in a big way. So the dietary shift has been quite perceptible, and we, again, anecdotally speaking, my father tells me that this used to be grown in such a common way in where we come from. Kodo is like a round kind of a millet. It's called barnyard millet, and it was easily available, or maybe but he says now we don't find it because nobody grows it. Everybody is growing wheat. So this whole focus on millets has been there right from the top leadership level. And even in the PDS system, it's being encouraged that you have to add millets in the, somehow in the, the messaging that goes out as well as in the diet. And this has been taken up by a lot of states. Again, I would give the example of Andhra Pradesh. They have introduced millets again in the ICDS program. There are many who are introducing it in the midday meal school program as well. And there is a Poshan Mah, which is it's like a nutrition month that is celebrated in the Women and Child Department in the month of September. A lot of this messaging is given out on how to make laddus, how to make biscuits, those matris out of the various millets that are available, using jaggery instead of refined sugar. So all that kind of messaging is being given. But you see, it is not visible because it is happening at so many different levels in different places. But yes, I think maybe a kind of convergence of these efforts would go a long way. So we are trying to converge our health. We have something called health and wellness days, which are supposed to be VHNCs, which are supposed to be done with the panchayats. So that if the panchayat becomes the fulcrum, then the ICDS and the health can work together to spread this messaging better. And the states which are using the platform of the panchayats gainfully are able to do that kind of messaging more effectively. So it is essentially using those kind of platforms that are available, which are cross-cutting, which don't think departmentally, but which can be used for spreading that message. Similarly, we have a Bal Swasthya Karyagram, which is a school child health, health program. So there have been joint, it has been repurposed. The whole program has been redesigned to have health and wellness ambassadors in schools, which are the teachers, which are supposed to talk not only about adolescent issues around reproduction, sexual, health and all that, but also nutrition, what is good for them, what diets are good for them. So we need to leverage those platforms. So the RBSK and our Kishore Swasthya Karyagram, which is our adolescent health program, need to work in tandem. And we are already working on that, on how to, ensure that the right kind of messages and the right kind of information is being made available to them. So for adolescents, for example, a peer educator program can be very, very useful, because they like to listen to each other rather than being told what to do. And there are a lot of barriers in approaching a teacher. So peer educators have also been created, and so that they can talk to them about what is good for them. And coming back
Thank you so much. I think we are running out of time, so maybe you can wrap it up for us.
Right. Yeah. So the regulation thing, like again, I would like to close with that. So the check on advertisements is very much there. It is there in our FSS Advertising and Claims Regulation 2018, and there are a lot of campaigns that FSSAI has made around it, which says that how these are like short videos which nudge people to say that we'll eat a little less sugar, we'll eat a little less salt, thoda sa kam, aaj se thoda sa kam, which means from today we'll eat a little less sugar, we'll eat a little less salt. So those kind of messages, just like our Swachhta Karyakram, which rode very strongly on a mass media campaign through the TV, as well as using celebrities, using the TV as well as the radio. Maybe some sort of a mass campaign can go a long way, and we can work on that, and I think it will be a good idea to have something like that in the near future.
Wonderful. Thank you so much. I think we can spend 1 more hour on this, and we would not still be done. But we are out of time. Actually, we are over time. I want to be respectful of people's time. So Dr. Arora, Dr. Hu, Dr. Singh, Ms. Singh, thank you so much. As I said, this is only a starting point of a conversation. We'll continue to hold these conversations through Harvard Chan India Research Center to advance our understanding and actions around these public health issues. I want to thank my team who have worked diligently behind the scenes in pulling this off. And I want to thank the audience who joined us today and have, I'm sorry I couldn't get to all your questions, but as I said, we will continue this conversation again. So again, Dr. Arora and Hu and Ms. Singh, thank you so much for joining us. Take care.
Thank you. Bye.